My name is Ian McIntosh, and I'm the Deputy Director of Disability Outreach for the Patients' Rights Action Fund, or PRAF. Joining me tonight as co-host is PRAF's Executive Director, Matt Vallier. And for the benefit of some of our allies, I'm a middle-aged Caucasian man with brown hair, gray plastic-framed glasses. I'm wearing a white button-down shirt with a blue and white cardigan, and my background is blurred. A special thanks to everyone who has joined us today. We've had tremendous interest in our Fighting Assisted Suicide Coast to Coast webinar series, which is a testament to the hunger that exists across our network of allies for the latest information, deeper insights, and specific information that will help inform advocacy efforts. So thank you all. Tonight, we're very honored to be joined by 4 distinguished panelists who each have an important perspective and insights to provide as to the state of play on assisted suicide in Canada, which will no doubt further our efforts to fight deadly and discriminatory assisted suicide legislation here in the U.S. Dr. Ewan Goligher is an assistant professor of medicine and physiology at the University of Toronto. Amy Hasbrouck is the founder and executive director of Toujours, Vivant, Not Dead Yet Canada. Our third speaker is Dr. Rene, Leiva, family physician and assistant professor at the University of Ottawa. And our last speaker of the evening is Dr. Ramona Coelho, family physician and a founding member of Physicians Together with Vulnerable Canadians. We will make all attendant affiliation links available on our website later. But before we get into a few housekeeping items, I'd like to mention a few encouraging updates to begin this 2023. In Virginia last week, Senate Bill 930 was defeated by a vote of 9-5. Also, the Alzheimer's Association on January 29th produced a statement on terminating their relationship with Compassion and Choices. I'll read a portion. In an effort to provide information and resources about Alzheimer's disease, the Alzheimer's Association entered into agreement to provide education and awareness information to Compassion and Choices, but failed to do appropriate due diligence. Their values are inconsistent with those of the association. We deeply regret our mistake, have begun the termination of the relationship, and apologize to all the families we support who were hurt or disappointed. Additionally, we are reviewing our process for all agreements, including those that are focused on the sharing of educational information. As a patient advocacy group and evidence-based organization, the Alzheimer's Association stands behind people living with Alzheimer's, their care partners, and their healthcare providers as they navigate treatment and care choices throughout the continuum of the disease. Research supports a palliative care approach as the highest quality of end-of-life care for individuals with advanced dementia. Here. So a few housekeeping items before we get started. Our format today will entail hearing from each of our speakers in turn, and we invite you to send us your questions via the chat as we go along, and we'll try to address some of those as time permits at the end of the webinar, and we will take questions via the Q&A function. Please type the question, your name, and organization affiliation if you have one. If you are from the press, please advise which outlet. For any further media requests, please contact Bill Pierce at wpierce@APCO Worldwide. That's WPIERCE at APCOWORLDWIDE.com. The session will be recorded, and we will share the link on our platforms afterwards. And just as a reminder, panel and hosts, for anyone who's not speaking, please keep your mic on mute. For everyone's benefit, we will have closed captioning and an update with respect to our ASL. Our ASL interpreter was trapped in a storm. They're doing their best to get to a location where they can assist as quick as they can. I'm sure our thoughts and prayers are with that person. So let's get started. Our first speaker is Dr. Ewan Goligher, Assistant Professor of Medicine, Physiology at the University of Toronto. Dr. Goligher.
Thank you very much, Ian. It's a privilege to be participating in the panel session this evening. I have the privilege of starting off our discussion with a brief overview of the critical core ethical issues at the heart of this question about euthanasia. The question really that we're gonna try to get into this evening is what's wrong with deliberately and intentionally causing the death of the patient. We're going to address this from multiple different angles, but I want to, at the beginning, at the outset, move directly to address this question head on from an ethical standpoint. I have no relevant disclosures, and I would emphasize that the views expressed here are my own, not necessarily those organizations with which I'm professionally affiliated. What do we mean exactly by the term euthanasia? Well, as we'll use a variety of terms potentially throughout our presentations this evening. There's a range of different terms that have been proposed for this practice, but really what we're referring to is the act of deliberately and intentionally causing the death of the patient upon their voluntary request. And the basic issue here is that it's referred to in different ways as assisted suicide, as euthanasia. Other terms include physician-assisted death or medical aid in dying. And one can draw distinctions between assisted suicide and euthanasia in the sense that the patient self-administers the drug in the one case, whereas the physician or nurse administers in the other. But really, ultimately, these actions all come down to a healthcare professional acting in a manner to bring about the patient's death deliberately and intentionally. And that's the practice that we're addressing this evening. Since euthanasia was legalized in Canada in 2016, it's rapidly grown in popularity and acceptance. The first year after legalization in 2016, there were about 1,000 patients who died by euthanasia. And in 2021, that number rose to exceed 10,000, including a significant number of patients who did not have, in whom death was not reasonably foreseeable, but who received euthanasia anyways after the modifications to the laws made in 2021. So you can see the practice is growing in uptake and acceptance. And the question really is whether this is good news or bad news for Canada. And we want to argue this evening that this is bad news. What are the arguments or typical reasons given in favor of the practice? Well, first of all, that we're using death as a way of relieving suffering. And in particular, that the practice respects and promotes patient autonomy by restoring control and giving them the freedom to choose the manner and timing of their death, that we're upholding and maintaining human dignity. And so euthanasia is said to respect and promote patient personal autonomy by giving them the choice to die if they so desire. I think it's fair to say that autonomy is really the central moral value that motivates this practice. The suffering that patients experience that gives rise to requests for euthanasia is most frequently couched in terms of a loss of autonomy. And this kind of classic paper from the New England Journal and other subsequent studies have shown this time and again that really the primary reason people seek assisted death is not because of uncontrolled pain and symptoms, but rather because of a concern over loss of autonomy and a struggle to find a continued reason to live when life is not going the way that they want. Patients mainly seek it because they're facing decline in disability and loss of autonomy. Now, of course, the central moral objection to euthanasia is quite simply that it's wrong to deliberately take the life of an innocent human person. But those who argue or support euthanasia claim that that respect for life is really also about respect for autonomy. And the line of reasoning goes something like this: if life is satisfying to a person, and therefore if they find it desirable, that therefore, if you were to take their life, you'd be taking something away from them that they want. And in that case, life should be regarded as valuable by all. And and as a consequence, life should not be taken by any. This is really the way in which they conceive of the wrongness of causing death. It really all comes down to whether life is desirable to the person or not. And if it's the case that life is no longer satisfying to the person, and if they therefore no longer desire to be alive, well, that removes the basis for respecting the value of their life and removes the basis for a prohibition on taking life. And so thus it becomes morally permissible based on patient's autonomy to deliberately cause death. But what's pretty striking to notice here is that how we move from subjective or personal states of affairs, whether one finds life satisfying and desirable, to objective and universal rules about whether or not how everyone should value that person's life. And this leap from the subjective to the objective reveals the way in which we are attributing to the individual person a profound moral authority. And this idea that if somebody desires something, therefore we all ought to respect that desire, assumes behind this logic the objective, inherent moral value of the person. In other words, autonomy really matters because people matter. And this is the fundamental issue. What matters more, autonomy or the people themselves? So now when we talk about people being morally significant, or when we say that people matter, what do we really mean? What kind of value do we have in mind? That value can be either extrinsic or intrinsic. So to have extrinsic value is to be good for something, to be a means to a valuable end. It's really value arising from usefulness or utility. So an example of extrinsic value, that something that might be very valuable, would be stock in Apple. But that value is entirely related to its monetary value, its purchasing power, what you can sell it for. It has extrinsic value. It's valuable to you insofar as the stock price is good and it's useful to you. On the other hand, a great work of art, like the Mona Lisa, may be said to have intrinsic value. Value lies in what it is, not merely what it's useful for. And one way to recognize intrinsic value is to ask yourself whether the thing that you're considering is priceless or irreplaceable. And if it has those kinds of qualities, if it's priceless and irreplaceable, something like the Mona Lisa, then it very much has an intrinsic value. Now, if there's anything that we know of in our world that is a priceless and irreplaceable value, it is the value of each patient entrusted to our care. Each individual human is unique in personality and character and significance. Nobody can ever be replaced by anyone else. And each individual person is literally priceless. And they should be treated with the dignity that accords with this incalculable worth. This, of course, is why it's wrong to buy and sell humans, why it's wrong to enslave or traffic in humans. And we recognize, in recognizing that we're each priceless and irreplaceable, we recognize that each of us has immense intrinsic value. The recognition of this intrinsic value motivates great respect and care for the patient, including respect for their autonomy. Now, here we come to a fundamental crucial point. If we value something, then we value its existence. And if we don't value its existence, then we don't really value that thing. The value of an object or a person is tightly linked to the value of their existence. So just take a banal example, like a trip to the museum and you see some ancient artifact and you see the care with which the care that's taken to preserve that artifact, to keep it sort of structurally intact over time so that people can come and see it. It's a kind of fundamental link to the past. And the care that's taken to preserve these artifacts in existence reflects the value that we put on them. They're artifacts, objects of great value, and that's evident by the concern we have to preserve their existence. But suppose you were to find out that these artifacts are actually just forgeries. Well, then you're no longer concerned to preserve their existence at all, and you immediately recognize that that is evidence that you don't really value those objects any longer because they're forgeries rather than having genuine intrinsic value. And so this highlights the fundamental connection between the value of an object or of a person and the value of their existence. The value of a person, the value of their existence go tightly hand in hand. And here we come to the crux of the matter. If we accept that something has intrinsic inherent value, if it's deemed priceless and irreplaceable, then it's good that it exists. And if something is good in and of itself, then by definition, its existence is a good thing. It is better for it to exist than not to exist. Now, the act of euthanasia denies the claim that the patient's existence is inherently good. The logic of euthanasia says it's better for this person to be dead. That's why we're causing their death. And that entails that you're denying that their existence is inherently good. But if their existence is not inherently good, then neither can they themselves be of intrinsic and unconditional value. They can't be, they're no longer regarded as a priceless and irreplaceable because we're willing to end their existence. If intrinsic and unconditional value entails the inherent goodness of existence, then if you deny inherent goodness of existence, you also have to deny intrinsic and unconditional value. And so we see that calling it into question the goodness of a person's existence devalues the person themselves. Euthanasia not only calls into question the value of individuals, it also unavoidably calls into question the value of whole groups of people. And although euthanasia is said to be a matter of personal autonomy, we don't just offer it to anyone who asks for it. Even in Canada, with one of the most liberal regimes in the world, most Canadians are not eligible for assisted death. Rather, we specify eligibility criteria in law that decide who should be eligible. And these criteria in turn reflect our background conception of who actually benefits from being dead. And however well-intended these criteria might be, they represent socially sanctioned criteria that communicate a concerning message about the values of our society, about whose existence could be considered optional and whose existence could be considered essential. So if we're willing to offer euthanasia to those with a chronic disability or serious illness or mental illness, or simply because people are impoverished and find the conditions of their life unacceptable, but we're not willing to offer it to healthy, well-to-do people who have no reason to us to seek death, well, that highlights a profound difference in how we value these different groups of people. Once again, if we call into question the value of a person's existence, we inevitably also call into question the value of the person themselves. And this is true not only individual level, but the level of groups in society. And I think what we're reliving in Canada now is a historical insight that was described by Leo Alexander in the New England Journal in 1949, where he surveyed how it was possible that the medical establishment in Nazi Germany came to be so profoundly morally compromised. And he observed that it started with the acceptance of the attitude basic in the euthanasia movement, that there is such a thing as a life not worthy to be lived. This attitude in its early stages concerned itself merely with the severely and the chronically sick. And we see how when we adopt an attitude like this, that we begin to devalue the lives and therefore the persons of some members of our society. So we conclude that it's wrong to deliberately and intentionally cause the death of patients. It's wrong to propose and permit euthanasia because it fundamentally devalues people. A willingness to cause someone's death entails that the person's existence is of no fundamental value. You can't deny the value of a person's existence without denying the inherent and unconditional value of the person. And if it's the case that people are really of priceless and irreplaceable value, no matter what the conditions of their life, we ought not to end them. And the concerning, grieving thing is that a euthanasia regime signifies that some members of our society are not as valuable as others. Some persons' lives are not worthy to be lived. And that really means that we're saying some persons are not worthy to be valued. And the truth is that while many of us sit comfortably thinking that, euthanasia is not that relevant to us, we're all fundamentally at risk. For all of us are vulnerable to injury, illness, disability, and despair, the conditions that predispose people to seeking death. And I think that is the essence of the argument. And as we continue the discussion this evening, we'll see in a very concrete way how these issues are being lived out in Canadian society at the moment. Thank you very much.
Thank you, Dr. Oliver. Our second speaker is Amy Hasbrouck. Amy.
Okay, thank you. I have a cold, so excuse my weak voice. To talk a little bit more and take from what Mr. Gallagher said, we'll talk a little bit about where we stand. As he said, there were, oops, I lost, oh, there it is. Okay, last year there were 10,064 people who chose euthanasia, who chose medical assistance in dying, and that was 3.3% of all deaths in Canada. And if you I put chose in quotes because we know that there can be no free choice to die, while old, ill, and disabled people don't have a free choice of where and how we live. From 2016 to 2021, 31,664 people died by medical aid in dying. And if we add what our conservative estimate for last year's 2022's numbers, we get nearly 45,000 people who've died. If MAID were counted as a cause of death by Statistics Canada, in 2018, it would have been the 10th leading cause of death. In 2019, it would have been the 9th leading cause of death, and it would have been the 7th leading cause of death in 2020, even considering deaths due to COVID. In 2018, the number of MAID deaths was comparable to the number of suicides. But in 2019, MAID deaths surpassed suicides by 1,100. How did we get here? We have to sort of start at a somewhat random place, and that random place is the case from 1993, Rodriguez versus British Columbia, where Sue Rodriguez, who was a woman in her 40s who had ALS, wanted help to die. The organization, the Coalition of Provincial Organizations of the Handicapped, which is the predecessor of the Council of Canadians with Disabilities, argued that Ms. Rodriguez needed a reasonable accommodation to commit suicide. CCD has changed their position because a disability rights analysis would disagree with that argument for two reasons. One is that there's no government-sponsored service of suicide to which access is required, and the government-sponsored service at issue is suicide prevention. The court ruled against Ms. Rodriguez, saying that the criminal prohibition on assisted suicide did not violate the principles of fundamental justice. And that was exactly contrary to what the Carter decision found in 2015. So 22 years and anyway, eventually an anonymous doctor provided her suicide. The Council of Canadians with Disabilities responded to another event in the early 90s, the murder of Tracy Latimer. Tracy was a 12-year-old girl with cerebral palsy who was killed by her father. Robert Latimer, her father, gained public support and sympathy by claiming he acted out of mercy because she was, her cerebral palsy was pretty severe and she had some pain. But the Council of Canadians with Disabilities argued that disabled lives should be valued equally and that homicides of disabled people should be prosecuted vigorously. And they intervened in legal proceedings. They did media work to try to flesh out Tracy as a person because she was used more as a symbol, and engaged in ongoing advocacy on the sentencing and parole of Mr. Latimer. In 1996, as I said, CCD changed their position to opposing assisted suicide and euthanasia, saying that CCD opposes any government action to decriminalize assisted suicide because of the serious potential for abuse and the negative image of people with disabilities that would be produced if people with disabilities were killed with state sanction. During the 1990s up to 2010, there were 11 bills in Parliament, all of which were defeated, including Bill C-384, which was defeated by a vote of 228 to 59. So how did we get from defeating an assisted suicide bill in 2010 to approval of medical aid in dying in 2015? The first Carter case was brought by basically three plaintiffs. Gloria Taylor had amyotrophic lateral sclerosis like Sue Rodriguez. Kathleen K. Carter had spinal stenosis, and then a couple of K. Carter's relatives also joined in the suit. The 2012 trial court in British Columbia, the decision was written by a woman named Lynn Smith, Justice Lynn Smith. She wrote a 400-page decision which really dismissed the arguments of disability advocates. And the language that was used was often dismissive and sarcastic. And the judge refers to protecting hypothetical patients from hypothetical harm. How did we get here? We got there also through Quebec's euthanasia law, because in Quebec, there was a consultation between 2010 and 2012 run by the Select Committee on Dying with Dignity, and their name sort of broadcasts their mandate. The act respecting end-of-life care was introduced in June of 2013 and adopted in 2014, and defines and permits medical aid in dying, or euthanasia only is allowed under that law as a medical service, allows continuous palliative sedation, but with few safeguards. The assessment and euthanasia must be done by a doctor. Only available to people who are at the end of life, but that term isn't defined in the statute. And the Commission on End-of-Life Care has issued 7 annual reports, all of which have shown compliance problems. So back to Carter, it wended its way to the Supreme Court, and on February 5th, 2015, the Supreme Court rules that the blanket prohibition on assisted suicide violates the Section 7 charter right of life, liberty, and security of the person by forcing people to commit suicide before they're ready to die. So that is their logic. And I feel their logic is bankrupt, but that's just me. It makes an exception for competent adults with a grievous and irremediable medical condition causing enduring suffering, and the person must consent to termination of life with physician assistance. And the Supreme Court claimed that the risks to vulnerable persons could be identified and substantially minimized by a carefully designed system that imposes stringent limits that are scrupulously monitored and enforced. And I am in the process right now of writing a book-length manuscript describing exactly how the current regime does not meet that standard. So the legislative process to adopt Bill C-14 began in 2015 with a conservative government in power, which legislated in slow motion because they wanted to study the issue. But the election in October of 2015, which brought in a liberal government, put the legislation on the fast track. There were 3 studies done, and there are links in the PowerPoint presentations to those studies. Disability community's challenge was how to constrain something that we don't even want. In the fall of 2015, the Council of Canadians with Disabilities, with Toujours, Vivant, Not Dead Yet, issued a statement of principles for any legislation governing assisted suicide or euthanasia, but we were saying assisted suicide, that were summarized in webcasts that I have links to in our PowerPoint slides. The goals that we wanted to recommend were to reduce requests by removing the causes of people's requests, allowing only assisted suicide and not euthanasia, requiring capacity to give informed consent to suicide. That would have created a new legal standard, but of course nobody went for that. And we also recommended requiring judicial approval. The vulnerable persons standard was led by Inclusion Canada, ethicists and medical professionals, which recommended equal protection for vulnerable persons, eligibility that should be restricted to end-of-life conditions, voluntary and capable consent, assessment of suffering and vulnerability, and arm's-length authorization. In other words, pretty much similar to what CCD was asking for. The compromise position arrived at was that reasonably foreseeable natural death eligibility criterion, and C14 was adopted in June of 2016. Bill C14 eligibility criteria all can be on the form that the doctor or nurse has to declare. All of these eligibility criteria can be checked as did not assess. So the person must have or be eligible for government funded health insurance, must be 18 years old and capable of making healthcare decisions, must have a grievous and irremediable medical condition, which is defined as a serious and incurable disease, illness, or disability. So they're saying that it's supposed to be only for people whose natural death is reasonably foreseeable, but they're also including disability by name. The person must be in an advanced state of irreversible decline. Their condition causes enduring physical or psychological suffering, which opens the door to people with mental illness that is intolerable and that cannot be relieved under conditions that they consider acceptable. In Belgium and the Netherlands, that standard is somewhat stricter. The doctor and the person have to agree that there is no reasonable way to relieve the suffering. So it's a stronger standard over there, and I think that makes a difference. And of course, the natural death has become reasonably foreseeable. The person has to make a voluntary request and be informed and give informed consent to MAID after being informed of the means to relieve suffering. That doesn't mean they get the means to relieve suffering or that they get effective means to relieve suffering. It just means they need to be informed. Safeguards under C14, no proof is required. This is all based on subjective measures, statements by the MAID assessor. So the person has to be, before administering, the doctor has to be of the opinion that the person meets the eligibility criteria, ensure that the request was made and properly signed, be satisfied that the request was signed by 2 independent witnesses. Now that's gone. Ensure that the person was informed that they can withdraw the request at any time, and several others. And the last but not least on their list is if the person has difficulty communicating, the assessor must take all necessary measures to provide a reliable means by which the person may understand and communicate the required information. This is a really major issue because a lot of people who are approaching the end of life either have, people with long-term disabilities have communication issues, or they may have just developed a communication issue, may not know how to deal with it, and the medical practitioners are not communicating effectively with these people. And this idea of a reliable means is far short of what would be required by the Americans with Disabilities Act, which would require a much stricter measure of reliability and effectiveness, effective communication. There have been several cases challenging Bill C14 as too restrictive, and they started immediately. So the first one to actually come out of a court came out in 2017, an Ontario court ruling for a woman, a 77-year-old woman with osteoarthritis, who was on a trajectory toward death because she met all the eligibility criteria. The first one to be filed was Julia Lamb and Robin Morrow's cases. Julia Lamb had spinal muscular atrophy, and Robin Morrow had Parkinson's, and they filed the same month it was adopted and claimed that Bill C-14 violates Section 7 of the Charter of Rights and Freedoms because it doesn't allow MAVE for conditions that are disabling that don't cause death. And the charter challenge that the case challenging C-14 that ultimately overturned most the reasonably foreseeable natural death requirement was a case out of Quebec that was filed in June of 2017. The plaintiffs were Jean Truchon, who had cerebral palsy, and Nicole Gladu, who had post-polio syndrome. They challenged Quebec's end of life requirement and Bill C-14's RFND requirement. And the case was driven by Gladu's fear of and Truchon's actual experience with forced institutionalization. The Quebec Superior Court rendered its decision on September 11th, still a very bad day for many people. So it had a similar tone to Carter 2000, the first Carter decision from the trial court, really snarky, and at the same time praising, lauding disabled people who want to die while ignoring people who advocate for freedom from nursing homes. And that's definitely been the situation in Quebec. So out of that comes MAID Redux. Bill C-7, adopted in March of 2021, codifies the elimination of the RFND requirement and creates a two-track system. Track 1 is for people whose natural death is reasonably foreseeable. RFND is not defined again. So again, there's lack of clarity about what it means. It eliminates the 10-day reflection period and provides broader, easier, and faster access to euthanasia. Track 2 is for people whose natural death is not reasonably foreseeable. People with disabilities basically are targeted there. It requires a 90-day waiting period, but that can be waived and it will probably be challenged in court. The required consultation about palliative care and disability supports, once again, does not guarantee that the services will be available, timely, or effective. Bill C-7 goes beyond the Truchon Gladu mandate by reducing the number of witnesses from 2 to 1, and the witness can be an attendant. It allows scheduled euthanasia, which allows waivers for the final consent capacity requirement, and creates de facto advance requests, and allows MAID for mental illness, which is supposed to start in March of, in basically next month. But in December, the Justice and Health Ministers announced that they wanted to delay implementation, but in order to do that, they're going to have to adopt legislation, and that would take longer than the time they have between now and then. There was supposed to be a 5-year review. It ended up being a 6.5-year review. The original mandate was that the provisions of the Act and the state of palliative care were to be reviewed by a joint parliamentary committee. The report may recommend changes to the law, and it was supposed to be finished by June of 2021. Now, obviously, COVID came along and screwed everybody up. The revised mandate, which was issued in April of last year, includes the original mandate plus study of possible expansion to mature minors and people who lose capacity, so who would access MAID via advanced request. Protection for persons with disabilities. Hey, we got a bone. and made where the mental disorder is the sole underlying medical condition. An interim report on how to implement that was written in June of last year, 2022. They've held 31 meetings from April to December of 2022. They've seen 150 witnesses, or more than that actually, and only 11 were people with disabilities. And that's remarkable because, of course, every person who requests or receives euthanasia has a disability, whether or not they also have a terminal condition. How Canada's law differs from other jurisdictions. There's a great article. I'm not going to get into it beyond saying that there's a great article, and there's a link to the great article. And lastly, I want to talk about Tale of Two Jurisdictions. Comparing California and Canada, they have similar populations. California is 39.24 million, and Canada has 38.25 million people. Both laws were adopted in June 2016. But if you look at the numbers, and especially down at the total, only 2,000 people have died in California from assisted suicide. But in Canada, 31,000 people have died. Why did I get that number? Anyway, so there's more information, there are links, and thank you very much.
Well, thank you very much, Amy. We will provide those links that you've mentioned for use on our website. And with that, Dr. Leiva.
See here, just 1 second. Sure. Sorry. Tell me if it's Is it the right screen? Sorry. Can you?
Yeah.
Yeah. Okay, so about that. Sure. Is it showing the right screen?
Yeah, yes, we can see slide 1, Dr. Leiva.
Okay, perfect. Thank you.
I think you'll want to remove the preview slide.
Okay. Having the same problem. Screen 1. What about now?
There you go. Perfect.
Perfect. So I'm really grateful and honored to be here to try to show you a little bit of our experience in Canada. So my presentation is going to be mostly on the impact on the medical and other healthcare providers situation in Canada. So I think about 10, 11 years ago, even probably more than that, I had the first red flag when I read the first example that was coming out of the impact of euthanasia on the medical profession came out of Holland. And the Dutch Medical Association put forward a position paper, was the role of the physician in the voluntary termination of life. And one of the sections that really struck me, or shocked me actually, was that they were actually saying that if somebody asks for suicide, the physicians are legally permitted to refer patients for information that is available on the internet onto publication from book vendors about suicide, and in fact, they commanded the physician to say that they had the duty to engage the patient when he was discussing the issue of suicide in the setting of euthanasia. Unfortunately, the cancer didn't stop there. The Canadian Medical Association in 2014 on the annual general meeting moved from the strong opposition of euthanasia to a neutral position. And it was no surprise that the guest honor was a member of the Dutch Medical Association that came to say that there was no issues in Holland in regards to the practice. So the Supreme Court used that as a springboard to justify the legalization of euthanasia in part. And almost immediately, the Canadian Medical Association said that doctor-assisted suicide or euthanasia was to be considered a therapeutic service. So by redefining euthanasia as these, the CMA made physician participation normative for the medical profession. And now we found in the position that refusing to provide it in the circumstances set by the law in Canada became an exception requiring justification or excuse. Unfortunately, the Canadian Medical Association didn't stop there and start promoting it on overseas. They would publish articles in the journals. They went to countries like Australia, as well as there was some promotion of the legalization of normalization of euthanasia in bodies such as the World Medical Association in 2018. Fortunately, that didn't become a reality. So the first impact that we had on the profession was what I said, destroys the trust in the medical profession. For example, right from the beginning, I remember this picture going around. This is from one of the main hospitals in Toronto. On the emergency room, on the TVs that they usually, you can see information about different type of medical interventions or medical advice. There was this message that says, MAID, how we call here euthanasia, is a legal medical service in Canada, whereby physicians or nurse practitioners help patients fulfill their wish to end their suffering. So here is being promoted in the emergency room, waiting room. So it does become a reality for this young lady, Candice Lewis, who's now she's deceased. She died of natural death. When she was in one of her times that she went to the emergency room in Newfoundland, her mother, who was not with her at a particular time, even though she was very close by, she heard a doctor telling Candice that while she had not asked for anything about it, that euthanasia was an option for her daughter. And unfortunately, a lot of people who have who are vulnerable, they sense the fear, they have the sense that they whether it should be a duty to die. More recently, there was a recent study that shows that Canada is really doing very well on donations after euthanasia, organ donation. As a matter of fact, from all the countries that have the practice, more than half of the cases are done in Canada. In Ontario and Quebec, which is most of the cases, it's promoted the practice of organ donation. So in part of the protocol is you have to have the patient agree to euthanasia or MAID before you can offer organ donation. However, once the patient it's approved for euthanasia, they are going to be getting the offer by the doctor to have that option to donate their organs. Obviously, there is an emotional component there, because most likely that patient who is, there is a risk that that patient is going to feel that he cannot or she cannot back down after he has promised to give part of her body or his body for somebody who needs it. There is also the problem of physician error and abuse. For instance, in this particular case that was very famous at the beginning, doctors in ER in Quebec, patients who were committing or attempting to commit a suicide, they were showing up to the emergency rooms, and the doctors, because they were not sure whether it was suicide because of euthanasia or suicide because of psychiatric illness, they were just letting them die. And to the point that the president of the Quebec College of Physicians had to remind the emergency doctors that they needed to treat all these patients. They couldn't make assumptions that these patients wanted to euthanasia, and therefore they wouldn't require treatment. There is also the question we always ask when we hear these cases: how did she or he got approved? There was a famous case in Toronto from a young man, 23-year-old man, Keanu, who was depressed. He has diabetes. He has lost vision in one eye. He felt really down. So he got approved for euthanasia, even though he wasn't dying. Fortunately for him, his family found out about it, and they stopped the process due to a campaign that her mother and her family initiated. There's a very good documentary that was aired about 2 weeks ago by Fifth Estate, which is from the CBC, A Complicated Death. You can look it up on that link, where there's this case and also other cases that is very, very distressing to see. There's also the cases of the doctors getting off the hook. We were wondering if doctors will do their best to try to dissuade the patients from suicide, and that's especially striking in psychiatry, because the law has approved psychiatry for mental illness alone. It hasn't become the practice hasn't become commonplace, because the government is still deciding how to implement. But it has, whether it's going to be delayed or not, we don't know. But the law has already been passed, and it's just a matter of time that the practice is going to start. So is the psychiatry meant to help people or not? There is also the corruption of compassion. For instance, in this particular case, is a CME from the University of British Columbia Department of Medicine, is how to help kids to learn about euthanasia. And one of the recommendations is to consider having the children present, to involve them in the process, to explain exactly what's going to happen, even show them the syringes, the stethoscope, the IV supplies, and this is considered a way to help the children to learn about more about the practice. An important part is obviously the vulnerable. Is probably the most important one, and part of the problem that we have now is that there is not much evidence. In Ontario, which is the largest province in Canada, the current documentation is very, very poor. I mean, you can see here, there's 4 or 5 questions that really don't do a service in terms of documentation. There is a more recent guidance document coming from the federal government, which is much more complete, but is not going to be necessarily mandatory in certain provinces. And in other provinces, it will be voluntary. So we have to wait whether we are going to be able to collect some useful information in terms of protection for the vulnerable. And also the impact on the doctors themselves, in their conscience, in integrity. So that's when integrity becomes inconvenient for the access of euthanasia. Like in Ontario, the appeal court has said that regardless of doctors' conscience or convictions, moral convictions is going to be that has to be put to the side, and the doctor must provide the referral for that patient to be connected to the practice. And if they don't, if by any chances the new drafts coming down the pipes from the college is that if the patient doesn't manage to access with the first doctor, the doctor will have to make sure that you connect the patient with the second doctor who will. And these are discussions happening right now. More recently, it's the Canadian Society of Palliative Care Physicians. They, in their submission to the federal government last November, talks about high levels of moral distress to members of the palliative care physician group because it leads to burnout, early retirement, and shift to other areas in medicine. And things are becoming really, really concerning. And even hospices has been hit by it. In British Columbia, in the Fraser Valley, which is south of Vancouver, there was the famous case of the Delta Hospice, which was refusing to offer medical assisted death. And they were saying, well, if a patient wants that, he can be transferred to the hospital, which was literally across the street. And the government of British Columbia said, no, we cannot accept that. So what they did is they expelled the board, which was anti-euthanasia, and took over the hospice. And this is despite that the hospital was literally across the street. Interesting to say that for people who are having organ donation in Canada, there is already cases where patients start the process in their home, they're put to sleep, and then they're transferred out and to the hospital where they're going to complete the process, and so the organs can be in good condition by the time they arrive to the hospital. So it's for that situation, there is no objection that the patient is put to sleep in the home, goes into an ambulance, and gets transferred to a hospital. On the other hand, for the hospice who gets transferred across the street, couldn't do that, and they have to be expelled. Also, the Physician Alliance Against Euthanasia has talked a lot about bullying of the doctors because they don't want to participate. There is cases of many physicians, especially palliative care doctors, leaving even for the latest development, having toxic practice environments, fear of discipline by medical regulators, and obviously doctors are not going to be promoting this or announcing themselves. They want to remain autonomous because they fear for their loss of license. And like this particular doctor who left the field, he says, anxiety, fear, and sadness surrounding my work bled into my family life, and ultimately felt that I could not manage practice palliative care at this stage in my life. And in some locations, for instance, hospitals' policies are being changed so to make it more difficult to people who are not in accordance with the practice of euthanasia. And they're looking to provoke crisis and confrontation to force objecting physicians to facilitate euthanasia or to have to refuse. So they are accused of obstructing access. All these leads on bullying and betrayal of collegial relationships, and again, poison practice environments and compromised practice care. And a case more recent, for instance, of this Dr. Sclater in British Columbia, who had to leave the hospice. There was because he couldn't practice anymore in this environment. So at the end, for those Americans, I would highly recommend, really fight any changes, any change of neutrality, any move toward any change in policy, both the level of AMA, both the level of world medical association, and anything, because at the end of the day, it's all about the vulnerable, and definitely something that we need to be very, very vigilant. Thank you.
Well, thank you, Dr. Leiva. That's we appreciate your work, and what a comes across as a shocking revelation, horrific as the events that have been unfolding on Canada are. And our last speaker tonight is Dr. Coelho.
Hi, everyone. And just, how is that? How's the screen? Is that good?
Perfect.
Volume good? Okay, great. My name is Dr. Ramona Coelho, and my practice is largely comprised of marginalized patients. If you're interested in written documents, several of my Canadian confreres have written 2 recent pieces, November and December 2022, in the World Medical Journal. But today, my talk is going to focus on cases in Canada. Donna Duncan suffered from a concussion, and it took over a year to receive specialized services in Canada while she continued to deteriorate. She requested euthanasia. Now, just to say, we call it medical assistance in dying in Canada. It's a euphemism for both euthanasia and assisted suicide. However, except for literally a handful of cases, to date, almost every case has been euthanasia. So I will try to use the word euthanasia for this American audience, but please forgive me if I slip back into MAID, okay? So she received euthanasia within 4 days of her initial request, despite having no terminal illness to her daughter's knowledge. They asked the police to investigate. The police were blocked because the hospital refused to cooperate, saying the daughters were not necessarily acting in their mother's best interest. So it's been over a year. Donna's death anniversary was, I think, a month or 2 ago, and these girls are deeply grieving with no recourse, no answers to why their mother's life was ended. Similarly, Alan Nichols had recurrent episodes of depression, but always recovered. He had some mild disabilities. A neighbor called the police when he was in his last depression. He was picked up and involuntarily admitted under our Mental Health Act. And to the utter dismay of the family, he received euthanasia. This was in the first regime, as Amy outlined, the Bill C-14, where you had to have a reasonably foreseeable natural death. To their knowledge, he didn't. His application request was labeled as hearing loss as being the reason for his application. Despite contacting the police, the college, they've been bounced around for years now. They've written over 40 letters to try to engage different authorities. Also, no answers for this lovely family that's suffering. Amy already covered the problem in Canada, and Rene touched on it, that, you know, it's about tick boxes that these MAID providers fill after the death of the patient. So Health Canada data collection is really inadequate. However, as Amy pointed out, several provincial bodies, as well as the penal system, have been picking up concerning cases. And there is there's a growing number of media stories that have been fact-checked and well-documented of patients who are receiving MAID under really troubling circumstances. And our Health Canada stats have not captured any of that. And lastly, to speak to this point, there is no oversight board where a family can go before or after a MAID death to find out what happened, to have closure. And so the Duncans and the Nichols are among other Canadian families who are suffering with no answers. This is a patient in my region of Canada. He had a small stroke affecting his balance and swallowing. Specialists said that he should regain his ability to eat normally and maybe walk with a cane, regain most of his balance. However, it was COVID, he wasn't allowed visitors, he was depressed, isolated, and he requested euthanasia instead. The euthanasia providers had no expertise in stroke rehabilitation and recovery. And while he was acutely ill, he had been diagnosed by psychiatry as having an adjustment disorder, isolated with no therapy to gauge his final level of function. They gave him euthanasia within a week of request, something like that, very close, like while he was in the hospital within 7 days. He had no terminal diagnosis, so it should have been 90 days according to track 2, as Amy outlined, but he was getting used to a thickened diet, so he did not choke, he did not aspirate, he was eating everything the kitchen was sending, but they were being prudent and sending him 1,300 calories a day just to help him, just to kind of make sure he didn't end up with an aspiration pneumonia. And the MAID assessor said, well, he's malnourished, and therefore we can end his life immediately under track 1. This case raises two concerning elements that we're seeing play largely in this regime in Canada. The first is ableism, and the second is a lack of understanding of recovery in chronic disabilities. So you can see, I don't know if you can see, but on the top right is a study which shows that physicians, this is an American study, consistently rate the quality of life of patients with disabilities as low. And if you look at the bottom, those list of studies where patients rate their own quality of life, even with severe disabilities, they rate their quality of life often as very high, actually as the same as age-matched individuals, even in severe stroke syndromes. Second part of this that I was talking about, a lack of understanding. Yes, there's a lot of literature about transient suicidality in patients with new injury and illness. However, this overwhelmingly resolves with care over a period of time. And so ending this man's life when he was acutely ill with good prognosis, all these things kind of suggest that the doctors probably had ableist views. And I didn't outline, I presume this group knows, but this idea that his life was not worth living, and that I didn't understand that he was going to enjoy his life if he was given a chance. This slide also in the region where I live, a 71-year-old widower admitted to the hospital with falls. Unfortunately, while there, he catches a diarrheal illness. He develops new shortness of breath. A hospital team member suggests that has he thought about euthanasia. So the euthanasia procedure is booked before he's even had his 2 assessments. And after 48 hours of his first assessment, this man is dead. His family is very sad. They wonder if euthanasia was raised to him because he was elderly and disabled, or was it because his admission had turned into a longer one? And could he have accepted euthanasia because his staff had made him feel horrible? When he had his diarrheal illness, he told his daughter that he could hear staff making fun of him, the smell of his room, not wanting to change him. And could these things have played into his decision to accept death under these circumstances? As opposed to other jurisdictions where this is legal, in Canada, there is no prohibition on raising MAID to patients. In fact, our Canadian Association of MAID Assessors and Providers, so you'll hear me say CAMAP, this is the group that trains MAID assessors and providers, has a document called Bringing Up MAID, where they recommend that all those who might qualify should be offered MAID. They should know about their options. But offering euthanasia to patients who have not raised it could effectively encourage suicide. And also it might speak to the patient that, wow, my prognosis is going to be terrible. Maybe I need to seek this way out. Secondly, very dangerous about a practitioner being able to raise the option of death is that we have a lot of conscious and unconscious biases. I just talked about ableism, it's devaluing of people with disabilities, but also, for example, in Canada, Indigenous specific racism is a huge problem. We have documentation reports about this being a problem in the healthcare system, leading to trouble accessing care, leading to negative health outcomes. We have the story of Joyce Etchiquan, First Nations lady, 37 years old, mother of 7 children, who died as she streamed onto Facebook Live hospital workers racially abusing her. And this disability group, I can't quote the whole thing, but they have worked with people with disabilities across Canada, and they are noting an increasing fear in seeking medical care. And they say people spoke of being afraid to seek medical help because they were worried about their physician raising the possibility of MAID. Some even went so far as to say that they will be avoiding medical care. Another one, this is my patient. After a national documentary showing a gentleman's euthanasia prevention as amazing, a patient let me know that this would be a good option for her. She's in her early midlife. She has a mild spinal cord injury. She can walk, but she hasn't had time to adjust, receive any peer support or proper symptom control. And yet she qualifies for track 2 euthanasia within 90 days her first assessment in Canada. This case, besides showing that 90 days is ridiculously insufficient as a minimum date of booking death, I think it also reflects a concern that many of us have about suicidal messaging, right? She watched this documentary, it was very attractive, it gave her this idea. And we know that suicide contagion is real. Like when Robin Williams committed suicide, the suicide rate transiently went up. We know that in Indigenous youth in Canada on reserves, that when one commits suicide, it can lead to very quick further suicides in the days that follow or months. Suicide contagion is a well-documented phenomenon. The other thing is that the literature shows that exposure to lethal means, so access to guns, access to pesticides, increase suicide rates in those who are at risk, right? And so MAID, or euthanasia, is offering someone lethal means, right? And in a very kind of sanitized way. Expansion, like euthanasia expansion activists have repeatedly said to me, well, this is like a nicer way to go. If you're going to jump off a bridge anyways, if you're going to shoot yourself in the head anyways, so crude, I'm sorry, but why not just give these people a different way out, a nicer way out? Will there be more closure? I just shared about the stories where the families have no closure, and that this was not like a well thought out choice. But I think what's important to also note is that in European jurisdictions, which have legalized assisted suicide, suicide rates go up. So bridge jumping and gunshot wounds don't decrease. The overall suicide rate goes up along with new assisted suicides. Very, very troubling. I feel this is a very dark presentation. I'm so sorry. This case shows the false kind of romanticizing of MAID that we've had in our media. So All Is Beauty was a advertising campaign done by a huge upscale Canadian department store. And it shows this woman in her last days before choosing euthanasia, where she's in a forest, she's in a beach, she's with candles. And she says, even now, as I seek to help end my life, there is still so much beauty. This is Jennifer Hatch. After she died, a national news agency revealed that Jennifer had spoken up in June under a pseudonym. And she had said that she very much wanted to live, but she could not access treatment, and that she was going to try to access medical assistance in dying as a last-ditch effort to access palliative care and other services she felt that she was entitled to. However, she did not get access to those services. Instead, she was approved for MAID, and Jennifer Hatch died in October of 2022 at the age of 37. In Canada, we've had an outcry over this story. So our veterans, our heroes, being offered MAID, being offered euthanasia when they were seeking services. So this veteran, former Paralympian, told the parliamentary committee that she'd been trying to get a wheelchair ramp installed at her home for the past 5 years, but was instead offered medical assistance in dying. And it's been confirmed that other veterans, while seeking services, were offered the same. A psychiatrist who cares for the most vulnerable has pointed out, why are some politicians so upset about the offers of death to veterans and not to other groups of citizens? Whether my mental or physical disability has resulted from noble service to my country, or from a car accident, or from a brain disease, the bottom line is that each and every person deserves care and support. In the interest of time for questions, I'm not going to cover these in detail, but Raymond Bourgonet is just to show how desperation and a lack of services can lead to death, but he chose euthanasia over the atrocious living conditions of his long-term care center. Sophia chose medical euthanasia because she was unable to afford housing on her disability support income that could accommodate her multiple chemical sensitivities. So the federal government has seemingly made a commitment to making MAID available broadly, easily, in the name of ending suffering, but there remains no positive right to timely publicly funded healthcare in Canada or social services. So we are a publicly funded system, but some things are not covered, and many things are not timely. As the Canadian Parliamentary Budget Officer was asked to, he estimated that there would be huge cost savings when we allow Track 2, Bill C7. This was done just before Bill C7 became legal. And that makes sense, right? When we end end-of-life care, ending the need for end-of-life care by ending people's lives as they're dying earlier, and also when we end the lives of people with disabilities by many years, then yes, we'll save on home care and social and disability and many other things. It's a very impoverished way to look at what a budget is for. And also, it's a perverse disincentive for governments and hospital administrators, healthcare authorities. It's very, very troublesome. Our federal cabinet minister for disability inclusion said, it is easier to access MAID than to get a wheelchair in some parts of the country. So CAMAP, I had mentioned them before. This article, I suggest everyone reads and watch the videos. The videos are of the group that trains our MAID assessors and providers, and they admit to things like doctor shopping is totally okay to find someone who aligns with yours so that you can go forward and do the euthanasia, that they consider poverty a defensible rationale for MAID. They suggest at one point that if you're not comfortable, you should make an effective referral. And one expert who's training MAID assessors and providers chuckles as she shares that family anger is probably the biggest problem in completing MAID. Despite these videos of the actual group that is doing the assessments coming to light, admitting these cases, you should read the stories, and all these media stories of individuals that are quite detailed, expansion lobby groups like Dying with Dignity are saying that our cases are thin on substance and being misrepresented by the media. They have a myth and facts page that says, fact, suffering from a lack of social services alone does not qualify a patient for MAID. No one can receive MAID on the basis of inadequate housing, disability supports, or home care. It's like nothing to see here, please look the other way. However, different leaders in the MAID movement, the euthanasia expansion movement, have made statements that also admit that this is happening. So Stephanie Green, Dr. Stephanie Green is the president of CAMAP, of the MAID Association for the MAID Assessors and Providers, says, our healthcare system is woefully inadequate. And yet, but I do not think we can hold these patients hostage. She's talking about a patient who has long COVID, who's applied for euthanasia, and she has stated that she wants to live, but she can't afford to live because she can't work anymore. The second one is a prominent Canadian bioethicist talking about limiting MAID for those who are poor. It says limiting MAID would translate into removing the agency of decisionally capable patients without offering them a way out of their predicament. And Dr. Ellen Leib testified in Parliament in May 2022 that she had at that point assessed 750 people for MAID and provided it 430 times. She said, I told my patient there was a 5-year waiting list for the specialist in their area and asked them whether they were willing to continue suffering for the 5 years. And they said they weren't. And I said that was irremediable. These statements ignore the predicament of these people that our society has actually created through structural inequalities and has led to making death an attractive choice in the first place. And in Canada, we have a huge, it looks to me from a study actually that we did, that there's a very small group ending the lives of a lot of people. So just in conclusion, this is Amy's image that she shares from Not Dead Yet. But the absolute prohibition of assisted suicide in all its forms remains the best societal protection from wrongful death from all people, but especially vulnerable and marginalized people. As the normalization of MAID as treatment continues to push forward, many safeguards in the standard of care that had helped patients recover and leave well is instead in Canada being replaced by an expedient death. Thank you.
Thank you, Dr. Coelho, Dr. Leiva, Dr. Goligher, Amy, for an extraordinarily informative and sobering presentation. We have 9 minutes left, and we have a question. One concern about the expansion of assisted suicide in the US is that it could result in the erosion of availability and or quality of ethically based hospice and palliative care. And he asks, is there objective evidence of this happening in Canada?
I think Rene should answer this question.
I mean, it's I would say in the time that we have, I think Ramona, probably what we can do is we can submit all the documents from the federal government interviews, and because that will be a good resource for people to have, where they can scroll down all the information that has already been submitted to the federal government, and that provides.
Sure, I think the question was asked though before, Rene, you covered Delta Hospice, which is a hospice that lost its right to do palliative care. And there's that same threat happening in Quebec in the new bill. Amy, do you have anything to say about that?
I don't have anything specific, although again, Quebec is about to launch another round of another piece of legislation to make it easier for people to get access to medical aid in dying or euthanasia, as it's done in Quebec exclusively. And they are tightening the screws on hospices, basically saying a hospice has to get permission from the health minister to not provide MAID, and that's not forthcoming.
I think also there was a religious exemption that is being lost, that is being threatened anyway. So up till now, our history, a lot of the hospitals and hospices were started by religious organizations before we started our publicly funded healthcare. And there's a big struggle now in terms of trying to pressure religious places to do this.
And as I explained to you also, there is this big pressure on that particular hospitals and hospices, because the whole argument is what we call it the transfer of care. Patients who request euthanasia when they are already in these locations, and usually it represents a small trip in an ambulance to a hospital that will accommodate them. And that's being fought as being cruel, and despite the fact that they are doing the same thing with people who are going through organ donation.
And in all instances, it seems as though from every direction, there's this compression to hasten the process. I know that from a report out of Oregon noted that the duration of physician-patient relationship in assisted suicide cases has decreased almost in half, from 12 weeks to 9 weeks to 5 weeks. Have you found in your care in Canada that there's been a similar trend in which the relationship between the patient and the physician has just decreased over time, COVID notwithstanding?
I can comment on that. Only I've been looking a lot at the reports, and only about 14% of doctors had a prior relationship with the person. Of MAID assessors had a prior relationship with the person.
Okay, and Dr. Coelho, there was a point made about the parliamentary budget officer, and could you, this notion of cost savings in the U.S. we talk a lot about the implications of a profit-driven private healthcare system, given how pricey some of the end-of-life care has become relative to the cost of assisted suicide, obviously. And on the other side of the coin, the cost-cutting policies in public system seems to always be constrained and pursued to keep the system sustainable. In Canada, it seems like there's an undergirding to make sure that it's again falling where it doesn't need to be. And if memory serves, and perhaps you could correct me, the parliamentary budgetary officer only noted a 0.08% savings of the entire Health Canada budget.
So the parliamentary budget officer actually didn't project savings. He based his estimates based on what he said were the current savings and based on end of life care. And this was before we expanded it. I mean, we have really been abusing in Canada reasonably foreseeable natural death. As Amy pointed out, there was a 77-year-old woman where the judge said her death didn't have to be imminent and her condition didn't have to be terminal. So basically, because she was 77 and with osteoarthritis, she could receive our track 1. But the parliamentary budget officer's estimate was actually quite conservative, given what's happening in Canada.
I think also for our purposes, there is this sense of hollow safeguards that protections are being removed, and that there's the idea of non-terminal diseases being eligible for assisted suicide in the U.S. is forthcoming. But for all intents and purposes, non-terminal MAID has been available in Canada essentially since 2019. Could you speak to the U.S. audience about this idea of language and misdirection and the need for vigilant opposition?
Sure. So since 2016, you're supposed to have a reasonably foreseeable death. It's 2021, so it's relatively new that this expansion is for outside the end of life. But I would say that there is no safeguard. You can look at the European jurisdictions that have better safeguards than we do. But even in the Netherlands, if you look at studies there was one that showed geographic variation of euthanasia rates. And a lot of it, I think, has to do with community support. Does the doctor value the life in front of him? And it comes down to a lot of the ethical things that Dr. Ewan Goligher mentioned, that this is really the devaluation of certain people, putting them at risk. There's no safeguards to protect you from a doctor who doesn't think your life is valuable.
And I think it's pretty striking that since that legislative change was made, so many of the really disturbing things have begun to emerge. Things like hearing veterans being offered or having maids suggested or euthanasia suggested by, workers at Veterans Affairs and so on. That really represents that progression down that slippery slope, accepting that some people's lives are not worth living, and really buying into that way of looking at the world. And that was a really significant change. But unfortunately, the natural progression of euthanasia logic in the first place.
I would just add that before 2021, when the C7 actually went into effect, we've been gathering a database of questionable eligibility. And all of the cases but one are people who did not have a terminal illness. And there are 70 cases in our database. And that doesn't include some of the people that Ramona mentioned.
Absolutely. This has been fantastic. Thank you all so very much. We are at 6:30. That's full time. And we will make this webinar available on our website and on YouTube. And again, thank you to you, Amy, Dr. Goligher, Dr. Coelho, Dr. Leiva, and to everyone. Have a good night. We'll do our best to work on unanswered questions and get those to you in a timely manner. Again, thank you all for attending. Good night.